Good afternoon and welcome to the FEMA Region 2 Individual and Community Preparedness Webinar Series. My name is Allison Albright and I am the Regional Preparedness Liaison for FEMA Region 2. I'm going to provide a few technical considerations before we begin. Today's proceedings are being recorded and captioned. The archived event will be available on the FEMA website in the coming weeks. You should be hearing audio through your computer speakers, so please ensure that your volume is turned up so you may hear the proceedings accordingly. In the bottom of your screen under the presentation, we ask if you'd like to receive news and updates from Region 2, and if so, please enter your email address and we'll be sure to add you to the distribution list. If you would like to increase the size of the presentation today, you can click on the 4 arrows pointing in all directions in the top right corner of the presentation pod. We will have a question and answer session after the presentation concludes. You'll see a Q&A pod in the lower right-hand corner. Please feel free to submit your questions about the subject matter there, and time permitting, we'll do our best to answer them. Finally, the PowerPoint presentation from today will be available for you to download in the file share pod as a PDF. You can click on the file and download it using the download button. With that, I'd like to turn it over to the Region 2 Community Preparedness Officer to introduce our speaker and today's proceedings.
Thanks, Allison. Did you know that FEMA's Goal 1 in our 4-year strategic plan is to build a culture of preparedness? The Region 2 Individual and Community Preparedness Program is focused on preparing individuals and communities for disasters by providing useful information and training, inspiring people to take action and be ready for any emergency. Good afternoon, everyone. I'm Debbie Costa, the Community Preparedness Officer for FEMA Region 2. On behalf of our team working to strengthen preparedness across New York, New Jersey, Puerto Rico, and the Virgin Islands, I'd like to welcome you to our preparedness webinar series. As part of that goal, we're pleased to be hosting today's webinar on preparedness and planning considerations for dialysis facilities before, during, and after an emergency. We have an excellent panel of speakers today. Our first 2 speakers are Chris Brown and Yessi Cubillo. Chris is currently the Executive Director of ESRD, End-Stage Renal Disease Network 3, covering New Jersey, Puerto Rico, and the U.S. Virgin Islands, and ESRD Network 4, covering Pennsylvania and Delaware. He has been in the ESRD Network program since 2004, when he began as the Data Manager of Network 3. He became Executive Director of Network 3 in July 2009 and of Network 4 in December 2015. Yessi is the Regional Emergency Preparedness Coordinator for Quality Insights Renal Network 3, 4, and 5. He has been instrumental in the maintenance of the network's emergency preparedness and response initiatives and actively promotes sustainable partnerships and activities among emergency management representatives, renal community partners, dialysis providers, and other stakeholders to prepare, respond, and recover from disasters and/or emergency events. In September of 2017, Mr. Brown and Mr. Cubillo worked with local and federal partners in the U.S. Virgin Islands when Hurricane Irma destroyed the infrastructure of St. Thomas and necessitated the evacuation of all dialysis patients to Puerto Rico. Just weeks after Hurricane Irma, Mr. Brown and Mr. Cubillo were in Puerto Rico when Hurricane Maria impacted the island and worked with local, territory, and federal partners there to help restore critical dialysis services to the over 6,000 patients on the island. I'd like to turn the microphone over to these 2 gentlemen. Chris and Yessi, it's all yours.
Thank you very much, Debbie. Thank you, everyone, for attending the presentation this afternoon in the midst of what I know is very difficult times for everyone with COVID-19 going on. So thank you for taking the time to attend and listen to our presentations. I have a couple of objectives, Jesse and I do, for our part of the presentation today. We want to give you an overview of what ESRD, end-stage renal disease, is, and kind of a very, intro course of what dialysis is. We want to describe what ESRD networks are and what CASER is, as well as how they might be able to assist you in your response and recovery efforts in different areas of the country. And we're going to give you a report on the 2017 disasters that Debbie spoke about, Hurricanes Irma and Maria, and their impact on ESRD patients. I do have a little sliver, a few slides that go over the COVID-19 impact on dialysis patients as well. So starting off, what is end-stage renal disease? It is the final stage, stage 5, of chronic kidney disease, meaning that the kidneys are functioning at less than 15% of their normal capacity. At that point, patients need either a regular course of dialysis or a kidney transplant to continue to live. The leading causes of CKD and ESRD are diabetes and hypertension. And you know how prevalent diabetes and hypertension are in this country, so you can imagine how many patients begin dialysis every year. When kidneys cease functioning, they can no longer remove waste from the blood or excess fluid from the body. So you, if you do not have a transplant or a regular course of dialysis, you become fluid overloaded, and if you do not get treatment, you pass away in very short order, which is important in times of disaster when you think about, services may be interrupted, electricity, water, things of that nature, and how patients not getting dialysis may be in very dire circumstances very quickly. So what is hemodialysis? This is kind of a graph that was taken from the NIDDK website. Essentially, blood is removed from the body, put through a couple of pressure monitors, blood pumps, heparin is introduced into it to prevent clotting. It goes into a hemodialysis filter, which is kind of blown up here on the right side here. And essentially, blood flows through the filters in one direction, water flows through in the opposite direction, and the toxins from the blood, to put it simply, are basically washed away from that water, and the cleaned blood is then returned to the body. There are 3 basic types of dialysis access that you might see if you're dealing with dialysis patients, kind of signals that this is a dialysis patient. The first and kind of unfortunately the most common thing you'll see is the hemodialysis catheter there on the top left. 2 tubes that are generally inserted right in that general area in the upper chest. One is for removing blood from the body. The other one is to return the blood to the body. The second one, top right, is a peritoneal catheter. This is something that patients who are dialyzing at home generally have, and that is something where fluid is introduced into the body and the blood is cleaned kind of overnight through a very long process. But when you see a tube coming out of the belly like that, it's generally a patient who is on peritoneal dialysis at home. The last one is kind of indicated by the kind of extended tubular structure you see on the arm here in the bottom picture. That is a fistula or graft, and that is the access arm that's shown there. Important to know what the access arm is because you should not be using blood pressure cuffs on that arm. So if you see an arm that looks like that, make sure you talk to the patient, see if it's something related to dialysis, and if so, do not use a blood pressure cuff to take the blood pressure on that arm. So talking about ESRD patients in shelters, there are some really specific things that apply to the needs of ESRD patients. First is dietary. Generally, we recommend that patients have a diet that's low in sodium, low in potassium, so avoiding bananas, orange juice, grapefruit juice, beans, and cooked greens is important to adhere to that diet restriction. A diet that's low in phosphorus, so avoiding dairy, caramel sodas, and whole grain bread and beer is also something that we recommend patients do. And then restricting fluids, because even though they're getting a regular course of dialysis, it's generally only 3 times a week for 4 hours each time, and there is considerable danger of fluid buildup if they take in too many fluids between those dialysis sessions that are going to take the excess fluid off. Medications like insulin may need refrigeration, something to keep into consider when patients are evacuated shelters. Like I said, no blood pressure cuffs on the access arm, and then determination of dialysis modality. Are they getting dialysis through that catheter, through the fistula or graft on the arm, or is it something where you're going to need peritoneal dialysis supplies in order to give them dialysis that way. So understanding that there are different ways that a patient can get dialysis is very important in dealing with this population. So kind of giving you a picture of what some of the national players are in the country related to dealing with dialysis patients and managing emergencies. The first one is CASER, stands for the Kidney Community Emergency Response. This was created after Hurricane Katrina occurred in 2005 and really devastated the New Orleans area. At that time, there were, as you can imagine, quite a few patients in New Orleans who fled the affected area. And we spent months exchanging spreadsheets to try to find where these patients had gone. Or were they still being treated? Had they passed away because they were not able to get treatment? Things like that. So kind of respond to that and to make sure that that kind of event did not happen again and losing track of patients, the CASER coalition was established. Their mission and vision are to develop, manage, and maintain a coordinated preparedness and response program for the entire nationwide ESRD community, and to serve as a leading authority on emergency preparedness and response for the nationwide community by providing the resources and guidance to address the unique needs of the population. They're headquartered in Tampa, Florida, and I will also say that this is made up of all kinds of stakeholders. If you are dealing with ESRD patients or ESRD facilities, the facilities that treat these patients, all of those types of entities attend regular CASER calls. And as you can imagine, since COVID-19 began back in March, there have been weekly, sometimes more than weekly, calls with the community to discuss strategic response to the COVID-19 impact on the dialysis population. So what is an ESRD network? We are contractors with the Centers for Medicare and Medicaid Services, otherwise known as CMS, division of HHS. Three main responsibilities, although there's a lot of detail in here that I won't get into, but overall, high level, we are to oversee the quality of clinical care provided to patients in dialysis facilities and transplant centers, receive and address patient complaints concerning the care they receive or how they are treated, kind of an interpersonal level in the facilities, and then relative to the discussion today, we are to act as a liaison between dialysis providers and patients and the federal government in times of disaster. Generally, 18 networks in the country, and they're owned by 7 larger companies. So if you ever run into an area where you are responding to an emergency, this is kind of a blow-up of how the 18 networks are split up geographically. And there's a link at the bottom there, esrdncc.org. You can go there, look at this map, and clicking on any one of these areas will bring you up contact information to contact the network. The reason I say that is networks have access to a lot of valuable information and data that could be relative and important to you as responders in these areas. For instance, the dialysis facilities in the impacted area, the number of dialysis patients that might be displaced by the disaster that's occurring. Also the staff, the dialysis facility staff, their contact information and numbers of them that are in the different areas. And all of these networks, as I mentioned earlier, are required by CMS to assist you in your efforts to respond to disasters wherever they may occur. Just giving a national picture broadly, national dialysis overview. This is as of the end of the year last year, 12/31/2019. We have 468,000 plus patients in the country on dialysis. The average age of those patients is 62.7, although almost half of them are 65 or older. 48.4% of them are 65 or older. Almost 15% of them reside in nursing homes. And I'm sure some of you are kind of connecting the dots on what that might mean with the COVID pandemic and how we know that has impacted nursing homes. 86% receive care in dialysis facilities, and the remainder, 13.7%, are the ones that receive home dialysis through that peritoneal catheter that I mentioned and showed on an earlier slide. As I mentioned, diabetic, hypertensive, very high comorbid conditions. 46.6% of all these patients are diabetic. 30% are hypertensive. They tend to be male, so 57% of the patients are male. And then just a racial breakdown, 34% of them are African American, 57% are white. Of the dialysis facilities in the country, we have 7,300 total. And the good news here is that if you ever are responding to an area, you're probably not going to have to deal with each individual facility on a one-by-one basis, because there are a couple of large entities that really own the bulk of the facilities in the country. They being listed here, DaVita owns 36% of all dialysis facilities in the country. Fresenius owns 34% of all facilities in the country. And then you see there's three other kind of smaller players, but still chains that if you were, let's say hypothetically, responding to a major disaster in Florida, by coordinating with the network, DaVita and Fresenius, you'd probably be taking care of the vast majority of patients being treated in that state.
Good afternoon, everyone. This is Yassi. So before we get into the discussion about the events that took place on September of 2017, we want to give you a picture of what the dialysis community looks like in Puerto Rico and the U.S. Virgin Islands. And at the time of September 2017, we had a total of 240 dialysis patients spread across 4 dialysis units. And from what you can see in the pictures, the U.S. Virgin Islands and the proximity to Puerto Rico is not too far. So you could easily take a trip there back and forth within the same day, within hours, less than an hour or so. But there are 2 for-profit dialysis centers owned by a physician in the U.S. Virgin Islands and 2 government-owned hospital-based centers at the time in the U.S. Virgin Islands. We'll get a little more into details what happened to those providers after the hurricanes and their current status, but we wanted to give you a clear picture of what things look like in the U.S. Virgin Islands as a result before the hurricane. Some of the preparedness activities that we had established in the U.S. Virgin Islands before the hurricanes in preparation for any events or just the work that we're doing with the dialysis centers as well. We did conduct facility visits every once a year at least, and we did meet with the governor's task force to address any needs within the dialysis community. We did a full facility visit of all providers in October of 2016, which was an opportune time for us to get to know the players on the ground and exchange numbers and get to know them face to face, so that in any future events we were able to have a better communication and a better understanding of the work that they did, and as well as what is it that we can assist them with in the event of an emergency or within the projects that we're also implementing. So it did build strong relationship with the staff on the ground. With the facilities, CMS has close monitoring of the work that is being done there, and as a result of everything that has happened, we do have now established very good relationships with Office of Emergency Management specifically, and more now than ever as a result of COVID-19. We have a good participation and membership with the Emergency Support Function 8, which is public health and medical services. So we do have have been able to build good relationships so that we can maintain that situational awareness and be able to provide the support that the dialysis community needs in the islands. In Puerto Rico, I want to also be able to give you a picture of what the dialysis community looks like, and in that picture you're able to see where the dialysis centers are located throughout the island. At the time there was a little bit over 6,000 dialysis patients spread across 48 dialysis centers, and there is one transplant center in the island that provides services to the patient. There is one transplant center that is off island in Texas that does provide services to them, but they don't have a physical facility in Puerto Rico. And as you can see, Chris mentioned, there is a large presence from what's known as large dialysis organizations, and Fresenius and Atlantis are the 2 large dialysis providers in Puerto Rico that in the event of an emergency or anything that happens in any of these providers, you can work directly with their corporate partners so that you can be able to deal with any emergencies that are happening. Some preparedness activities that have occurred in Puerto Rico way before the onset of the, I was going to say the pandemic. I'm in COVID-19 mode. The events that happened on September of 2017, we, in partnership with community organizations as well as the dialysis organizations in Puerto Rico, we came together to establish what's now known as the Puerto Rico Emergency Preparedness and Response Activities Renal Coalition. and the acronym is prepararse. So we did that on purpose. The name is in English, but the acronym is in Spanish. We came together to address issues that are relevant to the dialysis community, but more important, our goal was to build a resilient community that can also partner up with Office of Emergency Management, Department of Health, and first responders, or anyone that's going to be providing assistance to the dialysis community, and bring awareness as to what is it that might be needed in future emergencies. And we've conducted tabletop exercises together, and we've dealt with a severity of emergencies that have taken place at the in Puerto Rico, counting the droughts of 2015, the large power outage that it had in 2016, and so on. And so, what we want to focus today is on the hurricanes, but we want also to highlight that there are the other emergencies that we've come together to address and work hand in hand to develop and implement tabletop exercises.
All right, so let's get into the story of Hurricane Irma and Hurricane Maria. So going back to September 3rd, 2017, this storm had been brewing out in the Atlantic Ocean for quite some time. Obviously, all of us kind of keep track of what is the storm's track going to be. When we looked at this satellite map on September 3rd at 9 p.m., and we saw the size of it, the direction of it, and saw, kind of what was in the crosshairs. See those tiny little dots of islands, St. Croix, St. Thomas, Puerto Rico. We knew we might be in for an interesting next few days. On September 5th at 8 a.m., we got a news flash that Irma was now a Category 5 hurricane with maximum winds of 175 miles per hour, the strongest Atlantic hurricane since Felix in 2007. It made landfall in the Virgin Islands at noon Wednesday on September 6th. You probably cannot see, but there's a tiny little dot right there that is St. Thomas. It's right kind of in the eye of the hurricane. If you can't see my pointer, right in the kind of the 5 o'clock position in that eye. So it was making a direct impact on St. Thomas. This is an app that measures the wind speeds. I don't know if you can see how big it is on your screen, but we got to 121 sustained winds around 3 p.m. on Wednesday, September 6th. So we needed to, as part of our responsibilities in being the liaison between CMS and the providers, we needed to begin to get an idea of how much this was impacting the on-the-ground situation in St. Thomas and the other islands in the Virgin Islands. We began to make attempts on the afternoon of Wednesday, September 6th, trying to make contact with someone, anybody, YouTube videos, whatever it might be, trying to get an idea of how bad the storm was on the ground in the Virgin Islands. We finally reached a St. Thomas dialysis staff member on her cell phone at 4 p.m., and she was rather harried. She was kind of sheltering in place at home. Her windows had blown out. She was kind of bailing water out of the house with a bucket while she was talking to me, kind of holding the phone with her shoulder to her ear, but saying that things were very dire and the winds were so strong they had actually blown the windows out of her car. So we knew, when there's that kind of devastation, that we might be in for some real challenges. The medical director of the facility on St. Croix called us and said that they were fine. Somehow they had heavy winds and rain, but nothing that was catastrophic. But he could not reach any of his staff on St. Thomas. The lines had been down. Kept trying. After that, finally at 8 p.m., I was able to get through to Schneider Hospital directly using their landline number. Just kind of Googled it and found what their phone number was directly at the hospital. Spoke to someone in the command center there who said that they had complete and catastrophic damage in Schneider Hospital. HHS the next day made the decision, because of the impact to the infrastructure of St. Thomas, to evacuate acute patients from the hospital. And then Thursday evening, that same day, the decision was made to evacuate the 120 dialysis patients to Puerto Rico, because right behind their Hurricane I storm, Irma, Hurricane J, Jose, was threatening right behind it, following a similar track. So the St. Thomas patients, the 100 or so patients that we talked about earlier, we had 120 ultimately. on St. Thomas who identified and had to be evacuated. They were evacuated 1 to 3 patients at a time via the small plane you see pictured there on the bottom right, all day Saturday and pretty much all day Sunday by the NDMS, the National Disaster Medical System, which I know all of you are familiar with. 118 of the 120 patients ultimately moved to Puerto Rico. One patient who had residual renal function, the RRF I have there, was able to stay on the island because he did not need a regular course of dialysis. It was kind of a maintenance thing with him. And then there was one patient who was a local radio celebrity who asked the governor for kind of a special dispensation to remain on the island, and he was given that and was allowed to remain behind. They were allowed to remain behind because there was just enough medical support on the island. The hospital, kind of remained open and could provide basic services to patients, but not anywhere near the 120 patients that would have needed it if this had not occurred. So these 2 patients stayed behind, but everybody else was moved to Puerto Rico. So some things did go well during the Irma response. The units had generators and water cisterns, so while these decisions were being made, patients were coming in and being treated and then told what the plan was going to be for evacuation, told to go back, kind of get a go bag ready to go, and then, when the evacuation details were ironed out, they'd be notified, rallied positions, things like that, for them to be actually sent over to Puerto Rico. There was a very good rally plan that was established with the staff and patients. We were pleasantly surprised to find that patients who had just lived through a devastating storm the day before showed up for dialysis at 5 a.m., the day after the storm, expecting that they would be able to get that treatment. Staff also responded. There was immediate assistance from federal responders. They were already on the island in preparation for the storm, and they were able to make the call, schedule the evacuations, and really make things run on the Virgin Island side very smoothly. There's also, relatively speaking, a small number of patients to consider here. We're talking about 120 patients, so it wasn't, a critical mass of patients that we had to move out. It was something that we could accomplish with those small planes and get done in a fairly straightforward fashion. And then as you'll hear from Jesse in a little bit here, there were some heroic responses from the Puerto Rico dialysis community to receive these patients as they were landing, being triaged, treated, welcomed kind of like they were, at a homecoming. It was good to see how the dialysis community in Puerto Rico responded to receive these patients. There were some challenges on the USVI side. Probably no surprise to anyone. Federal versus state conflicts was a bit of a problem. We had planned to start evacuating these patients on Friday, but because of these conflicts, we could not do that. It had to wait until Saturday to begin. And then there was a lot of confusion and conflicting narratives on Saturday and Sunday about which patients were on which planes, what belongings did they have with them, all kinds of things. And this is just kind of some stats from me personally, the number of phone calls, talk time, texts, and emails that I had just on Saturday and Sunday, trying to work with the federal responders who were on the ground in St. Thomas. I was at my home in Pennsylvania trying to coordinate, this evacuation. 3 major things we realized were problems: identifying, who are the patients. If we want to evacuate all the patients, we need to be able to know how many we're dealing with, who they are, and more importantly, where they are. In this particular area, we had some patients who were on St. John, which is an island off the coast of St. Thomas, who had been taking the ferry back and forth to get treatment. So we had to, coordinate with the urban search and rescue crews to figure out where the patients lived, get down there, pick them up, evacuate them. We also ran into this kind of issue where there is a rule prohibiting foreign nationals from being evacuated. You can't use HHS resources to evacuate foreign nationals, so we had to work with the British Virgin Islands, who had also been devastated by the same storm, and the British consulate to figure out how to get this patient out of St. Thomas back to the British Virgin Islands, which was a saga in and of itself. But a lot of details, here that were difficult to work through at the end of the day.
As Chris mentioned, I want to cover a little bit about what we identify some of the challenges, but at the same time, as he highlighted, the Puerto Rico government and partners on the island. They really came through for the patients. But it would be remiss of us if we didn't highlight some of the, as we do with any after-action report, identify what we could do better for the next time around. So when we transfer the patients from the U.S. Virgin Islands over to Puerto Rico, one of the things that many had concern about was dialysis, and that was actually the last thing that they lacked. That was the first thing they received when they got into Puerto Rico, and they landed in Puerto Rico. There was a doctor, a nephrologist waiting for them at the airport, and nurses waiting for them at the airport so they can assess them and evaluate any needs, any medical needs that they had, so that they can then take them straight to a dialysis center and be able to dialyze them. The concerns and the real problems came after, all right, what do we do with these patients now that we have them here at the center, and the dialysis providers are trying to figure out what is the next step, and so are we trying to figure out what is the next step. And making those calls to the operations center in Puerto Rico and San Juan, and addressing what are those needs and how many patients are coming. There was, at one point or another, there was a miscommunication, and there was not awareness of these patients being evacuated and coming to Puerto Rico without having any housing or any coverage for medications or other things that we found during the evacuation of these patients. But ultimately, the Housing Authority in Puerto Rico came through, and they were able to identify a location where the patients were able to shelter for the first night, and that was one of the hotels in the Isla Verde area of San Juan, Puerto Rico. And then after that, there were two other hotels where they transitioned to, and ultimately ended up in the convention center in San Juan, where they sheltered for a few days before being evacuated again. But one of the things we wanted to highlight is take into consideration if there is any future or evacuation of patients or movement of patients, to take into consideration. It's not just the dialysis component, but it's housing, prescriptions, and coverage. This is something that organizations in Puerto Rico had to come together to be able to address and provide that medication and coverage for the patients. Language barriers, although staff in Puerto Rico do speak English and understand, you have to realize that there is a different culture in the U.S. Virgin Islands, and their language and accents are, they do speak English, but it's a different accent, and merging those two cultures together, trying to understand one another, was also something that they had to overcome. Unaware of isolation status of patients, and what was that there was no medical records received from the patients. Although they did come with their medical records, it was taken away from them when they landed at the airport. So these are things to consider and keep in mind when there is future evacuations. One thing we'd like to highlight was the lack of familiarity with the CMIST. And I don't mean to say that emergency providers weren't aware of this CMIST framework, which is based on the emergency planning functions listed below. It's more of the awareness or familiarity of how does the dialysis patient fit into this component, being that there is guidance specific for integrating dialysis patients in the components of people with access and functional needs and disaster preparedness. And my colleague Kelly Boyd is going to get a little more into details later on in regards to this topic, but understanding that these patients have comorbidities that also would implement or require for them to be implemented into the emergency planning when you're addressing their needs, such as you have a patient who's physically not able to transfer from a wheelchair to an airplane, and a stretcher bed patient being able to be transported and then taken from one place to the other. So there are restrictions, there are physical and psychiatric conditions that need to be taken into consideration. One of the examples I could share with you is when one of the patients was in the hotel being sheltered. We directly received a call from these patients, as we had direct communication with them, and we received a call from a patient saying, I am stuck in my room and I need toileting assistance, and I have no one here to provide that assistance for us. So it is heartbreaking to hear something like that, and that although the evacuation and the process and everything happened and the dialysis providers were ready at hand to provide that assistance, there are other components that need to be taken into consideration and need to be included in the planning for future events.
Okay, so I'm just going to show a couple quick pictures here of St. Thomas and St. John, kind of before and after pictures. You see complete devastation as far as every bit of greenery was stripped off the island. St. John especially, was known as kind of like an island paradise. The before picture in the top center there, the green, lush nature of it, and then after the storm went through, how everything was just completely stripped off. That's the same general area on St. John, and you kind of see the difference between before the storm and after the storm. This is Schneider Hospital that I told you earlier was saying they had complete and catastrophic damage, and this is a picture taken from inside by one of the staff members and sent to us that shows, the collapsed ceiling and everything else and how badly they were impacted. So Irma Wrap-Up, so by the end of Tuesday, September 12th, all the St. Thomas patients have been evacuated to and settled in San Juan, Puerto Rico, and believe it or not, that's when the problems kind of began. Logistics for taking care of these patients were a constant problem for the next 5 days until Maria hit. I think what we do to sum up this whole evacuation notion for dialysis patients is providing dialysis to them is the easy part of the whole equation. The problem is figuring out everything else related to life. The food, who pays for it, what's it going to be, is it culturally appropriate, is it ESRD friendly, et cetera, when is it delivered, transportation to dialysis, arrival times, pickup times, is this transportation company working so early in the morning? Most dialysis patients on first shift begin their dialysis treatment at 6 a.m., which means they need to be picked up well before 6 a.m. So if your transportation company opens operation at 6, you've got a problem already. And if that first shift of patients starts late, the entire day of patients is impacted and everybody's late for the rest of the day. By 9:15, September 15th, all the patients had been moved from the Ritz-Carlton Hotel where they started, and you can imagine how happy they were to land there after evacuation, to a shelter that was the San Juan Convention Center in San Juan, Puerto Rico. Tropical Storm Maria became Hurricane Maria on Sunday, September 17th. So you kind of realize we have a situation here where patients are moved from one bullseye to another. So Hurricane Maria started heading our way on the 17th. Jesse and I had flown down to Puerto Rico on the 17th to begin to assist the federal responders in triaging the patients who had been evacuated from St. Thomas and work with the logistics issues. As I was in the airport flying down from Philadelphia to San Juan, I got the alert on my phone saying it was a Category 5 now, so knew I was flying into what could be an interesting situation. We got to the shelter. This is 3 pictures of that shelter. That center picture there at the very back of the picture is where all the patients were staying on cots, the ones who've been evacuated from St. Thomas in a giant convention center. The assistant secretary for HHS was down there. He came in and assessed the situation in the convention center, saw all this glass and steel in the front part of it, and decided that to keep the patients as safe as possible, it was best to move the patients out of St. Thomas and fly them, or out of San Juan and fly them to Miami to get them out of the way of Hurricane Maria. One flight was arranged, 2:30 p.m., Tuesday, 9/19. We had to find all the patients who were at different dialysis centers, make sure they got to the airport on this plane. 84 patients were evacuated, including 12 who went directly from dialysis to the airports and never got back to the convention center to reclaim their belongings, but we got them all out of there and on the flight on Tuesday afternoon. So Hurricane Maria made landfall in St. Croix as a Category 5, then in Puerto Rico as a Category 4 on September 20th. As any of you who paid even scant attention to the news realize, it devastated life and infrastructure on both islands. 110 patients were evacuated from St. Croix to Atlanta, and these are 3 pictures that I took when I was sitting with Jesse, looking at the storm out the window from our hotel. Immediate problems, communication systems failed completely. I think as we were watching out the window those previous pictures, we realized that the electrical grid had gone down in Puerto Rico. Landline phones had gone down. I have a Verizon cell phone, could not make any calls unless I was on the internet. Fortunately, we were in a hotel, the Sheraton, that actually maintained their internet connection. So we were able to email, use voice over internet for our cell phones, and have electricity through their generators for the entire duration of our stay there. Even satellite phones, we realized the hard way, did not work because of the heavy cloud cover, so we couldn't even use those to communicate. No municipal electrical power anywhere. The water delivery systems also failed because of the electrical system going down. And then CMS and HHS obviously needed an assessment. How much damage do we have, and what's the status of the patients? We received a call from the medical director on St. Croix at 5 a.m. on Thursday morning saying that, he was down. He needed help getting his patients out. Jesse went out to different facilities. He took that picture there in the middle about the one facility that was close to where we were staying to see the damage there. At the end of September 21st, 16 of the 48 facilities were accounted for. All of those were in the San Juan area, and 2 of the 16 had been damaged so badly that they were permanently closed. So we really had a lot of trepidation that when the full accounting took place, that we might realize that we had a major problem on our hands with the devastation that might have occurred throughout the island among these facilities. So that being said, it turned out that we. Go ahead.
Go ahead. I was talking. I forgot to mute myself. I would like to highlight that although this in this slide, as you can see, we were able to establish contact with all the dialysis centers by September 27. We commend the dialysis centers for their hard work, and by the 27th, although we knew their status, they had been operated from day one. The community itself came out to provide assistance. Patients, family members, the employees left their families so that they can go to the dialysis center and be able to clear up the center so patients can start coming in and receive treatment. So I do commend them for their hard work and being able to come together and at a moment of need and be able to provide that support. And one thing that we were able to continue doing, as I mentioned earlier, we didn't have to necessarily contact every dialysis center independently. We work with the corporate membership that we have and part of that Preparedness group that I mentioned, and they're actively participating with us and sharing that information, and we're collaborating with them and saying, all right, what is it that you need? We are the Emergency Operations Center. We can be that voice of bridging those needs and those gaps that we're identifying in the dialysis community so that we can be able to continue providing the support and the treatment that the patients need. And as Chris highlighted, one of the 2 main components that the patients needed during any emergency event and any response, it's water and water for the dialysis treatments and fuel for their generators. And let Chris share a little bit about what you're seeing in this picture here.
And I'm going to go through the next several slides fairly quickly. I apologize. I realize I only have 2 minutes left in my presentation, so I'm going to try to hit the high points. So early issues were kind of threefold. Couldn't get gas into the staff cars, so they couldn't even necessarily get to the dialysis centers to provide treatment for the patients. Fuel delivery trucks had been prearranged and pre-staged, but they were stuck on cargo ships in the harbor behind other ships, so we couldn't get that working very quickly, and then no source of water was identified. You saw earlier on my slides how much water is needed to clean the blood during the dialyzing process, and we could not get enough water for these patients. And it got so dire that the picture you see here was actually suggested as a potential solution to the water crisis. That is a pallet of water bottles, and someone from the U.S. Marine Corps suggested that we just start opening bottles and pouring them into the cisterns in order to provide dialysis. Obviously not something we wanted to do. So we learned a few lessons. Where to shelter in place during the hurricane. This is the amount of water that's needed. 6,000 patients in Puerto Rico, that's the number of gallons of water you need per week to provide dialysis to them. It's an extraordinary amount of water that's needed during dialysis. So just kind of keep that in mind for any kind of future responses you may be in, that we need a lot of water for dialysis. Facilities needed to establish independent relationships with local fuel and water companies. At the end of the day, it was those local relationships that paid off because the other federal and state level entities, there were too many kind of red tape issues in the way to allow that to happen. So really they relied on their local communication and relationships. And then hopefully this presentation kind of solves that last one, that now you understand how big an operation dialysis can be. Some things did go well. All the units in Puerto Rico have generators and water cisterns, so as long as you can refill the fuel and the water, we're good to go on that. Fresenius, as we talked about earlier, they have a very strong emergency response group, so they were able to supply all kinds of dialysis equipment to all the dialysis centers on the island, and they also have men in black for security because some of the trucks that were delivering water and fuel were being hijacked and redirected, so we had to have security accompanying some of those deliveries. Rally plans are well established, and the dialysis staff are extremely dedicated all over the country, but especially in Puerto Rico. Generators were a problem. Society can get to a place where it can break down rather quickly. We were in one hotel with the federal responders, and there were guys in black, armed military guys outside guarding the door, and someone pulled a gun on them to try to get inside to charge his phone. That's how sort of desperate he had become for electricity, that he needed his phone charged that badly that he wanted to pull a gun on federal people with assault weapons. Federal assistance can be delayed, as you all know, especially in a large disaster, and then the rumor mill, trying to chase down who's dying, who's not dying, are there patients stranded, can be an exhausting thing to go through when you're trying to respond to the needs are pressing in the community. Just a couple pictures of Puerto Rico. This was 6 months after the storm. I went back down there. This was the rainforest in Puerto Rico, pre and post. Pre is top left, post is top right. Signs still down the highways 6 months later, and this was a beach that was at one time considered one of the top 10 beaches in the world that was badly damaged. So right now, as of today, even 3 years plus after the storm, we still only have 2 mobile units on St. Croix. The hospital still has not been rebuilt. We're dialyzing patients in the 2 trailers you see pictured here, and we have one of those trailers also in Vieques, which is a little island off the coast of Puerto Rico that's treating about 12 to 15 patients 3 times a week. I want to give you a quick overview of the COVID-19 situation. The chart you see here, the line graph, is the year-to-date positive patients by state. That yellow line is New York. Was really bad back in the spring and early summer, kind of leveled off, but is now kind of heading in the wrong direction again. And we have Texas and California that have now spiked beyond New York, where this is just dialysis patients and the impact for them from COVID-19. If you look at it per 1,000 dialysis patients by state, suddenly you realize that states like South Dakota, which you probably see in the news, are now looking at it from this way, looking at dialysis patients per 1,000 impacted. South Dakota is as bad as New York, even though there's so much fewer patients. Most of them, a lot of them, have been impacted by COVID-19. For those of you who are data nerds like myself, you might want to check out this website or just Google USRDS 2020 Annual Data Report. It's a COVID supplement with all kinds of tables and graphs to show you the impact of COVID-19 on the dialysis community. I'll just give a couple highlights or lowlights as you might look at it. First is the mortality, all-cause mortality, and this is by week number of dialysis patients who died every week. You see up until COVID started, 2020 was just like any other year. And then suddenly 2020 got much worse than any year in memory. So, spiking close to 2,500 patients dying in 1 week, week 15 of the year in 2020. This is New Jersey. New Jersey showed a spike in the same months, looking at the same kind of data for the last 4 years. Number of patients dying per week never had gone above 73. And then looking at weeks 14, 15, 16, 17, 18, and 19, suddenly a major spike in New Jersey, including in week 16, where we had 185 patients die in 1 week in New Jersey. Looking at it, zoomed out a little bit, knock on wood, I know we're in the middle of another wave now, or beginning of another wave, but after that surge back in the spring, early summer, things in New Jersey kind of went back to normal, but as I said, things are getting back into a bad place right now. And that's all I have. Thank you very much for your attention. I know we're going to take questions later.
Thanks, Chris and Yessi. I was actually there at that same time, and I'm glad that you were so good at documenting things day by day, because it seemed like almost hour by hour something else was going on. Finally got the people of Puerto Rico, oh my God, now Maria's coming, so what can we do next?
Yeah.
So I'm glad that we have such good scribes to document the information and that we do take lessons learned from that.
Thank you.
Our next speaker today is Kelly Boyd. Kelly is an access and functional needs planner for the New Jersey Office of Emergency Management and a co-chair of the New Jersey Group for Access and Integration Needs in Emergency and Disasters, or NJ-GAIN. Additionally, she is the chair of the New Jersey County AFN Coordinators Group. Previously, she served as the Disaster and Disability Services Coordinator for the New Jersey Governor's Office of Volunteerism and as a disaster assistance employee for FEMA. Kelly, I never knew that about you. The microphone and the floor is all yours.
Thank you, Deb. And yes, that was back in my early days and how I actually met Jim Fleming.
Oh, wow.
Yeah. So thank you all for having me here today, and I really appreciate Yessie and Chris being a part of this. They've been very involved with NJ-GAIN, which is the New Jersey Group for Access and Integration Needs in Emergencies and Disasters, and also the County AFN Coordinators Group. So my presentation will talk a little bit more about the issues faced by dialysis patients and or their caregivers during the pandemic and other disasters. I'll also talk a little bit about the New Jersey Register Ready program and then provide some helpful information and resources. And I guess my dog thinks she's going to chime in as well. So
Kelly, can you please just speak up a little bit?
Sure. Let me try to move my phone. Is this any better?
A little.
Okay. I'll try to talk louder.
That's good. That's good.
Okay. So a number of issues arose during the pandemic that pertain specifically to dialysis patients. And Yessie had worked with me from the beginning to make sure I was aware of the needs that were out there and that I could work with our partners, especially folks at NJOEM, to make sure that they were addressed immediately. Some of the issues included arranging transportation of COVID-19 positive patients to clinics for treatment, also ensuring patients and caregivers could get to their appointments in spite of curfews or travel restrictions. There's a lot of confusion about that in the beginning, and also making sure patients and caregivers as well as staff at clinics had enough PPE, and last but not least, ensuring patients had backup assistance if caregivers contracted COVID-19 or had to quarantine because someone they lived with or was in contact with had it. So these are some of the partners that NJOEM has, and a few I've mentioned, but aside from Quality Insights Renal Network and the County AFN coordinators, I also work closely with county offices of emergency management, and Yessie was involved with me on that level as well when we were working with counties that had the issues with transporting individuals who were COVID-19 positive to their appointments. And we eventually got that going with the help of Logisticare and some sort of changing of the normal policies and procedures. Also, a number of the counties have core advisory groups. I see Carol Tonks is on here today, and Middlesex County was the first group to have a tag. A number of other counties have one. Burlington, Kim Matson's on today as well. Union, Cape May, Cumberland, Atlantic, Somerset, Passaic, Bergen, and Mercer's just recently started. So there are a few that are in the works and a few that we hope to get going soon, with the goal of all counties having a core advisory group, which really essentially brings together those working in the emergency management field and public health field with individuals who have disabilities and their advocates. So, these groups can work on a different level to address these issues. as they arise or hopefully pre-plan to avoid them. Again, I talked a little bit about NJ Games, and there are quite a few stakeholders who are members of NJ Games. And here on this slide, you'll see a few listed: Medical Reserve Corps, New Jersey Department of Health, New Jersey Department of Human Services, New Jersey Division of Aging Services, FEMA, and also groups like New Jersey Division of Disability Service and many others. So I know this is hard to see, and I think Chris and Yessi talked a bit about this, but again, these are a couple resources for folks who are interested. The ESRD network, and that is the website, and the CASER program, and below you'll see the website for that. And, you know, as mentioned, we had concerns where folks who were positive for COVID-19 weren't being provided with the transportation to get to their appointments, and it's very, very critical that they get to their 3 appointments each week. Fortunately, with the help of a number of counties and their emergency managers and other advocates, representatives from the Department of Health in the counties, and a lot of coordination from Yessi, the logistic care, the logistic care that's available in each of these counties, were able to step up and provide the transportation as needed. Yessi, I don't know if you'd like to add anything to that. I know it was quite a process.
Yeah, Kelly, I wanted to highlight that thanks to your partnership and Joe Galetta from NJGAIN as well, and other partners that are members of these coalitions and these groups, that we were able to work this request that came in from the dialysis providers and issues that were coming from the dialysis providers in regards to lack of transportation for COVID-positive patients or patients who were transferred to a cohort facility and now they couldn't get to their dialysis center because of that lack of transportation. So when we brought that and we provided the resources to the dialysis centers to speak directly to their Office of Emergency Management, County Office of Emergency Management, as well as those partners that you and your team shared, they facilitated that transportation and those resources for them. So I think that's, it works, and it helps to have those partnerships established before any emergency.
Yes, that's a good point. It is really key to get to know and form relationships with your partners who are out there, and hopefully have some agreements already in place, or if not, at least, like I said, a good working relationship, so it's easier to tackle any issues as they arise, especially things that sometimes just cannot be anticipated. In addition, aside from arranging for transportation, sometimes the groups work together to reschedule appointments, possibly take individuals to another clinic, which can be done in snowstorms and all that. There were sometimes caregivers who had come down with the coronavirus, and then folks needed alternate transportation resources. There was a lot of juggling. I'm going to go on to the next slide. Register Ready is a program that NJOEM runs. I oversee that, and as such, we encourage individuals with disabilities or access and functional needs, or their caregivers, to make sure that they're registered, and that way emergency responders and emergency managers can get a better idea of who is out there in their community and what their needs are, and then enhance their plans relating to serving those with all types of disabilities and access and functional needs before, during, or after a disaster or other type of emergency. It's free to register. It is voluntary. You don't have to do it. I just recommend it so we can better plan for you or your loved ones. It is confidential, and I did see a significant rise in the number of registrants during the pandemic. Many of the counties who use Register Ready make sure to conduct wellness checks, and not just one since this began, but multiple checks to make sure somebody is okay, whether they're in need of anything, and then also just to get a sense of what is going on out there in their community. And folks can, let's see here, go to registerready.nj.gov to sign up, which is the way I do it. It's not terribly difficult. For those who may be visually impaired or have other difficulties using the internet, they may want to call 211, which again is free to do, and there are translation services and TTY services for those who have hearing impairments. So obviously we're entering a second wave, which I keep hearing is going to get even worse as we approach Christmas and New Year's and whatnot. NJOEM continues to partner with Quality Insights Renal Network and other DAF and stakeholders, as well as the county offices of emergency management on planning, response, and recovery efforts. We've also been working with the New Jersey Department of Health. I personally serve on the Special Populations Working Group and the Logistics Working Group. So we are really making sure that folks who are vulnerable are included in planning stages and can get the vaccine as soon as possible if they so choose. And stakeholders continue to encourage the public to follow CDC guidelines regarding the use of PPE and making sure it's available, as well as social distancing. So these are just a few websites you may want to refer to, and I believe most of you have them, but I just wanted to put them down again. And happy to take questions or comments at any point, Deb.
So we're going to hold the questions until the end. This way we make sure that we get through all the presentations. But thank you very much. We are going to move on to our next speaker. We kidded around a little bit that said that you had to have the last name of Boyd to be part of this presentation. But our next speaker is Dennis Boyd. He has been, no relation, by the way, he has been an attorney for more than 30 years. For the last 6 years, he has worked in the legal unit of New York City's Department of Emergency Management, NYSEM, overseeing the city's compliance with the Federal Americans with Disabilities Act class action settlement. Before joining the city, he worked on impactful disability rights issues for 20 years, providing training, lobbying, and developing disability-related policy regarding deinstitutionalization, access to housing, health care, and public accommodations, and on the implementation of the Federal Help America Vote Act. Dennis, would you like to take over from here? If you're talking, you're on mute.
I was talking and I was on mute. I said thank you very much, Debbie. Good afternoon, everyone. And you know what, I was happy to hear all of these other presentations so far, because they really highlight sort of the application of the knowledge that goes into the kind of, preparation and readiness and response considerations that are relevant to people on dialysis and the whole dialysis system, and sort of the way in which the specific events of these hurricanes, Irma and Maria, et cetera, have impacted people is really illustrative of a lot of the reasons that I'm talking sort of about the legal background, the rights of people with disabilities. So I'm going to talk about the fact that people who are in end-stage renal disease are people with disabilities under the federal ADA, Americans with Disabilities Act, as well as an earlier law on the federal side called 504, which only related to entities that receive federal funds, and New York City law as well. The ADA and many state and local laws prohibit government discrimination on the basis of disability. Basically means treating people differently who have a disability for, a variety of reasons. And, some of the unique characteristics of the provision of renal dialysis sort of highlight some of the ways in which people may have differences that are tied to their disability and therefore to allegations of disability discrimination potentially. So explicitly I wanted to make clear that people who are on end-stage renal disease are often disabled not only due to their failure or limited kidney function, but they also have, not really comorbidities necessarily. They may have comorbidities, but they also may have other disabling conditions that impact the way in which services can be delivered to them. I highlight here mobility, communication-related disabilities, and other disorders that have to be considered in the context of emergencies. So the definition of people with disabilities under the ADA is a person who has a physical or mental impairment that substantially limits one or more major life activities, or has a record of such impairment, or is regarded by others as having such an impairment. So there are a number of elements there. I mean, obviously the substantial limitation, but the fact that, that only applies to the actual disability. That is, you can have a record of a disability and, somebody may see reference to your disability and treat you differently. And, there may be circumstances that suggest that you have a disability that, again, may cause people to discriminate against you. So New York State and New York City disability law do not have the component in the federal side of substantial limitation. In fact, New York City's definition is extraordinarily broad. And I only mention it because I think it's helpful for people to look at local laws to see whether or not they are more expansive than the federal laws, because the way the federal law was written, it allows for states and localities to be broader and more inclusive in their definition of disabilities and also with regard to the kinds of services and accommodation that are required under their laws. So under New York City, any physical, medical, mental, or psychological impairment or a history or record of such impairment, again, simply put, the major difference really is sort of the lack of the necessity for substantial limitation. And some of the requirements, basically under all of these disability laws, are that people be provided program access without discrimination, that public entities modify their policies, practices, and procedures to avoid discrimination whenever it's readily achievable. And again, readily achievable takes into account the cost involved and whether or not it would alter the fundamental nature of a program. And one of the efforts that has to be considered is always trying to integrate people with disabilities into the mainstream in the provision of emergency services. The kinds of things that are prohibited under disability laws include the denial of participation in services and benefits and programs based on disability, and applying separate eligibility criteria to people that would tend to screen out people with disabilities. The only circumstance in which that's possibly allowed is where it's shown that such a screen out or separate eligibility criteria is necessary in order to provide the service program or activity that people are entitled to. So it's basically in order to try to ensure the same kind of treatment, it may sometimes be necessary to make some sort of program changes that are particular to particular kinds of disabilities. So, as I stated earlier, end-stage renal disease patients often have a variety of other conditions, and those conditions have to be considered in terms of when, services are provided to people with end-stage renal disease. And those include sort of a whole variety of different things, some of which I've mentioned already. But I think some of the examples that Yessie and Chris and Kelly gave earlier sort of talk about, just temporally kind of the issues that arise in triage, in figuring out logistics, in figuring out the ability to get and keep medical records and ensure that transportation exists that's accessible to people who may have transportation-related or mobility impairments, and then communication with people, both people who have disabilities, who have sight impairments and hearing impairments, people who have developmental or language-related disabilities and may have a hard time communicating, but also, again, sort of these physical things that relate to service provision, water, enough water to provide services, fuel, power, generators, and, the specific equipment that's used in the dialysis process. A lot of times these are the kinds of things that we as emergency managers have to factor in. And again, on the New York City level, I am Disability Access and Functional Needs Coordinator. So a lot, what I and my team, which includes a number of people who are integrated into the different departments, there are about 14 people who have assignments that relate to disability access and functional needs elements within New York City emergency management. And those people sort of serve as a special team that the rest of the agency relies on to consider the kinds of unique impacts that a lot of these subpopulations of people with disabilities, the elderly, people with language access issues, et cetera, have during, really any kind of emergency you can imagine. Yessie mentioned earlier on the CMIS system, which is, basically part of the provision of services generally, but a lot of the elements in CMIS are heightened and very particularly applied to people with disabilities and other people with access and functional needs. Considerations around communication, maintaining health, independence, the services and support people need, and the transportation are all often very unique and individualized in terms of what the needs are. And so all of those things are, need a particular focus. And I'm really glad to be presenting along with all the people who've already presented, plus Anna Bennett, who serves in the same manner as the earlier presenters in New York State. So thank you very much, and I will accept questions at the end.
Thank you, Dennis. As Dennis mentioned, our next speaker is Anna Bennett. She has been with the IPRO, or Island Peer Review Organization, ESRD network of New York since September 2010 and serves as a network quality improvement coordinator and emergency manager. In her role as emergency manager, her work focuses on collaborating with local, state, and national healthcare emergency coalitions to ensure community preparedness, effective communication and reporting, and patient access to care in the event of a disaster. Anna?
Hi, thank you so much. And hi, everyone. It's so great to see so many of our CERT partners on this call, and I want to thank you. And I'm going to be wrapping up what you've already heard and just reinforcing so much that you've heard from Chris and Yessie and the work that they've done in the field in these emergencies, and what you've heard from both Kelly and Dennis Boyd from the state and the work that they're doing, and try to tie it all together for you and recap some. So the ESRD network program is contracted by Medicare, and there are 18 networks that cover all 50 states and territories, as you've heard. We are contracted through Medicare, and we work on a statement of work. We work in quality improvement. Chris is executive director for his networks. Yessie works both in emergencies and also in patient services, I believe. And all of us wear many hats in the networks to serve the community, and many of us are trained in emergency management. So you heard about CASER. That's our National Coordinating Center. And so CASER really works for all 18 networks, also is a CMS contractor that gives us resources and coordinates on that national and federal level with us, and collaborates with those large dialysis organizations that you heard about, the national groups that have multiple clinics and have big percentages in the state. But also, New York is very unique because we have so many independent and hospital-based, and there are also many, many nursing home-based dialysis clinics in New York State. So these patients are your patients. You see them in emergencies. You've heard about their comorbidities. You've heard about access and functional needs. You've heard about how unique they are, and dialysis could be just one of their disabilities. And remember that dialysis is really considered a form of chronic life support. These people's kidneys have failed, and without dialysis, they understand that they won't be able to sustain life. So there's also a heightened panic with dialysis patients too in an emergency, because they know without dialysis that they're in trouble. So we try to follow the 4 core elements of emergency preparedness, just as you all do: risk assessment, emergency planning. We all work on communication. We know how key that is. And when Chris talked about not, telephone, landlines, and not even having sat phones because of cloud cover, we always need to communicate. We focus on policies and procedures to make sure everyone's prepared, and training and testing is something that we try to work in all of our areas, and also nationally. CASER gives us a national drill every year where we participate in the exercises. And I have to tell you, when CASER gave us a pandemic exercise a few years ago, we pulled the annex for that to help us prepare for COVID-19. So the role of the network is really to advocate and support for patients and providers, to facilitate that communication, to make sure everyone has situational awareness, to make sure that we're reporting what's happening at the facility level and what's happening with patients, and to provide expert ESRD advice, kind of like what we're doing on this call with all of you, to let you know that we're available to agencies and responders, because we speak dialysis and we also speak emergency management. Our facilities speak dialysis perfectly. They're learning emergency management. But sometimes it's really hard for first responders and emergency managers to communicate, because they really are 2 different languages that we all need to share. So you can see that it starts at the federal level with Health and Human Services and the Department of Homeland Security, and it comes through CMS, through ASPR, through FEMA, through CASER for us here at the network, and we have the ESRD networks. We work very, very closely with the state Department of Homeland Services and Offices of Emergency Management, and also the local OEMs. And as you heard from Dennis, what we do in New York City, we have a seat that during Hurricane Sandy, we were able to have an embedded person from the network staff work in the EOC. Now we're supporting it virtually with ESF8. So that's really helping us a lot, and really helping us to advocate for the needs of our community with you all. We work with our dialysis facilities so that they're in communication with their county OEMs. So if they need something from the strategic stockpile, or if they're having transportation issues, we can act either as a conduit if we need to, or in some cases if they're more rural, or if they have an easier communication that's not overwhelming for the OEMs, they have direct contact. All dialysis facilities are required by CMS to have annual contact with the county OEM, and the networks are here to make sure that they're doing that. And then above all, we work with patients and family members and their care partners, because these are your patients, these are our patients, and there are so many stories that Chris was sharing with you about evacuating these patients. It's their care and safety and well-being that we really are looking at for our bottom line. We want to mitigate all of our casualties. We want to make sure that people have the best access to care that they can have. And like Dennis spoke with access and functional needs, this is something that's at the forefront, that we want to make sure that we're advocating for these patients and we're giving the providers what they need to be able to provide care during an emergency situation. So really quick with New York, we have 19 million people in the state, 330 dialysis facilities. That's with, around 5,000 staff members. 42 of these facilities are based in nursing homes. 33 are hospital-based or hospital satellite facilities, so they're part of a hospital network already. And in New York City, we have 140 facilities, so that's almost a state unto its own for us, with 20 skilled nursing facility-based, nursing home-based, and 17 hospital-based facilities. So that's a lot of patients. That's about 30,000 patients that we're treating. So when we respond to an emergency, this is pretty common. We set up an incident command. I'm giving you an example for what was done during COVID. We started early activation in February. We knew that there was something happening in January. We paid attention, and my CEO decided we're going to activate in February, and that's when we adapted the pandemic plan from one of our past drills and integrated it with our emergency plan, and we started reacting to the pandemic. We began 24/7 availability on March 2nd. That meant our phone became a hotline, and patients and providers could reach us 24/7. And as many of you know, and as Dennis alluded to, transportation started to hit us really hard very early. So we have dialysis generally 6 days a week. It's Monday through Saturday, and as you heard from Chris, it can start at 6 o'clock in the morning. Patients get there even earlier, and it can run up to a 4-shift, past 10 o'clock at night, and especially during COVID, because we now have cohort shifts where patients can be on that last shift of the day, all the positive patients, and that can make things be very late, which really impacted us when we had to shut down New York City for civil unrest. We had dialysis patients who were still dialyzing after the curfew, and we had staff members who had to terminally clean these units and these machines and go home to their family members after the curfew, and dialysis facility staff members who needed to get to the dialysis unit to open up the unit before the curfew was lifted. So this really did become a huge impact for us. So our team at the network, we moved all of our at-risk staff members to remote work and stay at home in March. All of our staff were remote working and staying at home when the order went into place, but we had complete connectivity so we could communicate and we could work with our facilities. We had daily team touch points, so we talk about what our plans are, what we're going to do. And we also have tracking logs, and that's where the reporting and the situational awareness comes from the network. Chris talked about the large dialysis organizations who are able to report nationally to CASER, so CASER knows what's happening at the LDOs. But in the case of New York, when we have so many independent facilities, we then have to work with all those independent facilities to get that reporting and situational awareness up to CASER, who can then report to CMS and can start working with all the federal level response that needed to come and is happening here in COVID. So that's what the network staff is doing when we're activating, and we're really responding to the COVID event and big events like Hurricane Sandy, and you heard about what Chris and Yessie did during Hurricane Maria. We really work to report out to all of our stakeholders and provide that situational awareness and activity reports so that everyone knows we're on the same page and we're here advocating for dialysis patients. So this couldn't be done without partnerships. And when I see the CERT people on the call and I see other names on the call from different coalitions that we're involved with, we have to partner with all of our community to make sure that we're all on the same page, that no one's doing duplicative work, and that our patients are being taken care of and advocated for. And we're providing technical assistance to help the facilities when they have an issue, to help the patients when they have an issue. Like when Chris talked about evacuating the patients, when Yessie talked about, the support that they needed in addition to dialysis. We talk about medication needs. All of these things we consider technical assistance, and we work to provide resources to help get these. We work with our coalition stakeholders, the Hep C stakeholders, a lot of nonprofits, all of our local and county OEMs at the state level. And we also have a task force here at Network 2 for COVID that really consists of providers, both at the hospital and the dialysis facility level, and patients to help us navigate all of the information that's coming out and make sure that everything we put out to the community is vetted by providers who are in the clinics, in the hospitals, and patients for understanding. So just to give you an idea, outside of these extraordinary events where everyone's activated, we also have day-to-day events. And Yessi alluded to that when he talked, winter storm can cripple us. We've had 210 closed dialysis days. That means those patients didn't have dialysis that day, so they have to be rescheduled. Or, they still, even with the snow event, we still have to worry about transportation and power outages. We also have altered schedules where, if they have to cut the dialysis schedule short, then, that patient's lost that time of treatment, and how are we going to recoup for that? We have power and water events, a lot of water events that happen because, as Chris told you, a lot of water is used to provide for dialysis, both in home dialysis settings and in dialysis facilities. So it's something that we always want to make sure that our patients have access to water, we have electricity. And other events, one of the more recent events was the work action. If there's a strike going on, we have to have a contingency plan, because if workers are going out on strike, as happened in New York City a couple of years ago, we need to make sure that those patients can be moved to another facility where they can have their treatment. Again, because if we're looking at dialysis as a chronic form of life support, we want to make sure that patients have access to dialysis by trained dialysis professionals in a safe environment, and that we're not cutting any corners, because it's still a technical process that needs someone who's trained in using the machines. And we have a lot of patients who are in home therapies, and we also have patients that are living with a transplant that are dependent on medications and are also immunocompromised. So ESRD is a very broad spectrum disease that's impacting hundreds of thousands of patients all over the country. So part of the network work that we do is we do communication, education, and outreach. So we give clinical guidance. We have a nurse on staff who's a dialysis nurse who can help with guidance. We also promote all of the guidance that comes out of the CDC and from CMS and from the State Department of Health and the local departments of health. We maintain a website. We send out email updates during an event. We want to make sure that all of our work is patient-centered, so we have a patient advisory committee, and we have patient subject matter experts that really, work with us to make sure that we're providing discussion groups for the patients so they can help navigate the time of COVID especially. We've created a virtual support group for dialysis patients in New York where they come together and they can really work because of social distancing. They're really feeling isolated. And we're giving weekly resource newsletters, and we've created a dedicated web page, and that all happened during the peak. And as you know, New York is now, as Chris showed you the numbers, we're coming up into wave 2. We really try to modify our messaging to the moment, and we amplify all of the messaging from the state, county, and local health departments and from CMS as it comes out, because we act as that conduit as well. So some of our community resources really are printed materials in electronic form, things about dialysis you can see on our website. You can send us an email. You can ask. All the networks have materials that have been developed to help dialysis patients, to help dialysis providers, and to help family members navigate the whole COVID world that we're living in right now, and navigate how their treatments may have changed, or if they're using telehealth, how they can integrate better practices, and amplifying the safe practices that we need to keep COVID suppressed as best we can. So these are just a picture of our website, our emergency messaging that we send out via email, and the resources and updates that we've had in the past 10 months. And just a reminder that, in addition to all the work that we're doing in the trenches, all the work we're doing in emergencies, all the work that we're doing in the EOCs, that also the people that are getting up every day and going to take care of our patients, those are also our dialysis healthcare heroes. And so we have a campaign for them to help them understand the work that they're putting in, the sacrifice that they're putting in this unprecedented time. So I want to say thank you to everyone. And I think now we can go over to questions.
Yes, thank you so much. We appreciate all the information from all of our speakers. That was really excellent. Our first question really could apply to several of our speakers, so I will let you guys decide who best to answer, or maybe the first one we could have several folks answer. But the question is, how did COVID-19 impact your work related to dialysis? What are some of the best practices learned during the pandemic? Is there somebody that wants to start with that? Maybe Yessi?
Yeah, sure. So as Anna highlighted, the shift that the networks took, most of us initially we went to work from home remotely and continued to maintain operations of our network work remotely and follow up with the dialysis centers and provide any assistance that we needed. It didn't really impact much of our operations per se, but I would like to highlight that the dialysis centers, which is who we worked hand in hand to make sure that patients and staff were safe, they did implement new guidances and also increase the level of precautions that they were taking at the dialysis center. So there was a shift in the dialysis centers to try to make sure that both patients and staff were safe, and COVID-19 wasn't at the dialysis center wasn't a source of spread. And to this date, knock on wood, that has been the case, and they have maintained good infection prevention practices. Anna, I know you talked a little bit about it. Would you like to share a little more about the work that you guys have done in New York?
Oh, of course, that could be a webinar in itself.
I know, right? You did actually do a webinar on it.
I have to tell you, infection control was the most important thing that we pivoted with, making sure that all of the facilities were able to isolate and to screen and to have proper PPE. So that was the first big practice change that we saw. Then, there was the drama with getting testing. We didn't have testing for the first month and a half that we were dealing with COVID in the facilities. So our facilities had to really kind of navigate testing. Transportation was huge because we had issues, and this is how Dennis and I really worked together with the city of New York, because we have over 15,000 dialysis patients just in New York City itself. And a lot of them rely on either public transportation, disability transportation, accessoride, and that happens in county disability transportation all over the state, but in New York it's very pronounced, or in Medicaid contracted transportation. We were very lucky that the Medicaid contractor in New York City really came on board very early and worked with us to try and mitigate any driver fear, because they would, they did figure out that we didn't disclose that the patient was COVID positive, but they kind of figured out from the shift changes and things, and it was a very difficult situation in the beginning. But the best practice that came out of it really was the communications and the partnerships, and New York State stepped up to the plate. NISM worked with the state, I worked with the state, Dennis worked with the state, and they came up with an alternative for transportation to use providers to get dialysis patients to treatment, and it really was successful. We had over 100 calls for need for transportation because of driver refusal or they had no access to drivers to get them to dialysis, and all of those were mitigated. So it really was amazing to have that happen in such a horrible time.
I can't even imagine with 15,000 people needing dialysis just in the 5 boroughs. Is there anybody else that would like to field that question before I move on to the next question? Either Dennis or Kelly, or Chris? Okay.
It's pretty well covered. You know, I mean, it was, you know, there was so much else going on, but, you know, it's just illustrative really of sort of, you know, how things jump off and sort of, you know, the manner in which all of these different partners just, you know, really lend a laboring oar and, you know, turn over every rock and do everything possible to make things work.
Good point. The next question, I believe, is asking if there was a problem or a challenge with the Emergency Prescription Assistance Program, EPAP, in Puerto Rico with patients from VI or from Puerto Rico?
Yeah, I'll take that question. This is Jesse. So, and the follow-up question it clarifies is because a lot of pharmacies didn't know anything about regarding EPAP, not just during the emergency, but also a long time after it. And I would like to thank the veterans group in Puerto Rico. They came through the VA, and they were the ones who were able to provide the medication for the dialysis patients who had been evacuated from St. Thomas to Puerto Rico. And together with the government of Puerto Rico, they were able to come up with a plan. For the short period of time that the patients were there, they were able to create a plan for providing that medication to the patients, as well in collaboration with the dialysis center. So that ultimately, that's how that resolved. But yeah, the EPAP was not a topic of discussion at the time.
Okay, thanks, Jesse. The next question is specific to New Jersey. They're asking if Morris County has partnerships. I'm not sure if they're referring to CAGs that Kelly was talking about earlier, or other partnerships with dialysis centers.
In regards to CAG, I can answer that. All 20 out of the 21 counties are part of a grant system where one of the work plan requirements is to establish a core advisory group, and Morris County is the exception. However, they do have a county AFN coordinator, and he is interested in trying to get a core advisory group going. I have to see where they are in that process, but I am hopeful. And in regards to the dialysis connections, I'll pass that over to Yessi and Chris.
Before Yessi answers, Kelly, are you able to share the name of the AFN coordinator for that county?
That would be Christine Hellier,
okay.
And she's with the Disability Services Office.
Thank you.
Oh.
Yessi, can you speak to partnerships in Morris County, New Jersey?
Yeah, specifically to Morris County, I don't have that information firsthand, but one of the requirements that CMS establishes for the dialysis providers is to develop a plan together with their Office of Emergency Management. So any plans that they develop for emergency response or any activities or exercises that are implemented, that is one of the measures that it's highlighted in their requirements. For when the Department of Health goes in and does an evaluation of their work, they need to be able to demonstrate having had contact with the county or local emergency managers. So it is a requirement, and if it hasn't been established, we do provide that resource and that support for the dialysis providers as well as the county emergency managers to kind of serve as a bridge between the two.
Great, thank you. So one of our speakers share how patients would manage through a power outage when they're doing home dialysis. Does the equipment have portable backup batteries or something to assist?
I can take this. I once upon a time was a home dialysis patient. The batteries you would need to be able to maintain the home hemodialysis machine would be excessive. You may be able to use battery backup with some of the peritoneal dialysis machines, but generally patients are asked to contact their local utility provider and be made priority for restoration if there's life-supporting equipment in the home, and the dialysis facility is charged to ensure that the patient has made that connection and that when a power outage happens, that they are then prioritized for restoration. Also, dialysis facilities, when a patient's doing home dialysis, and if they can't do dialysis at home, they can come back into their training dialysis facility for respite dialysis work, so they could be brought back into the center if the case that they couldn't do their hemodialysis. In the case of peritoneal dialysis, and I want you to think back to when Chris showed you that the belly, there was a tube coming out of the belly. Peritoneal dialysis can also be done as a manual exchange in an emergency situation. And patients, all home patients are trained in emergency processes and procedures for, what if this happens. So PD patients could do exchanges, manual exchanges, and home therapies patients may not have access to power to provide enough of a dialysis treatment, because dialysis treatments can be up to 4 hours at home, and can be overnight as well if they're doing nocturnal. But they can be brought back to their dialysis clinic for dialysis until power is restored. Did I miss anything, guys?
I think you got
This is Kelly. I was just going to echo that I just went through the process of registering with my power utility company, and it was extremely simple to do. I filled out a form which is very brief. My doctor just wrote a little note. They faxed it in. Within just a few days, the company called to let me know I was in the program, and then they sent the letter, and they also insure you, even if, something happens where you're behind on paying for a few months, they will not shut off your utilities, and I think every 6 months they'll just follow up to see if anything changes. So it's a great process, and it's also important to do that in Register Ready too, because it's a separate system. But again, it lets the emergency managers in your community know if you're relying on power.
That actually leads perfectly into our next question, which says, we've used Register Ready list many times. What are your opinions about Smart 911?
So there are a few counties that use that. Somerset is the newest to come on board. Ocean does use it, and Morris. What I have heard is that it can be a really great system, because if somebody calls 911, it'll come right up that they have a disability or some kind of a critical need. However, at the state level, we've looked into it, and it would be nice to use the system. However, the expense is astronomical, so that's why we'd be reliant on the counties to pick that cost up themselves. And like I said, some have done it, but it is separate from Register Ready. Certainly 911 call centers can get access to Register Ready, so there is that ability as well.
Thanks, Kelly. And our last question for our speakers, although I'm not sure who is best to answer this, but the question is, do you have legal nurse consultants involved?
I can speak for IPRO. We have registered nurses, nephrology nurses on staff. We have legal staff, but they're not. We don't have them on staff up a network.
Yeah, same thing for network, but we do also have, and most networks, if not all, have a board of directors and also a medical review board that has representation from nephrologists and other medical professionals in the field that we address any projects or any situations that are occurring in our network.
Yeah, all clinical work done at the network is done by licensed clinical providers. That includes our social workers who are licensed social workers, MSWs, and also our RNs who are licensed by the state and also have certification as a nephrology expert. and our board of directors and our medical review board, as Yessie explained.
Okay. We actually do have one final question, unless somebody types while I'm talking. There is a reasonable variation between the electrical dependent customer data maintained by HHS on their Empower map versus the data on electrically dependent customers maintained by the power company. Are these data sets ever reconciled against each other and compared?
Oh, that's an EOC question. That really is. That would be for the, I guess, the group that handles the emergency support for utilities in the EOC. That's something that we would have to ask those people to see if they're reconciling the and for each region if they're reconciling their data sets. I can't answer that for New York. I don't know.
Kelly, would you know for New Jersey?
I think it really depends on the county, and so I try to take a look at these numbers or whatever I have access to, but, you know, some things are duplicated, and it just depends what system people are using and connecting with.
Okay. Well, I want to thank all our speakers today. I think the information was excellent, and really appreciate you taking the time to sit down with our audience. We do have a terrific bunch of folks that join us for our webinars, and we do have probably another 6 webinars coming up before the end of the year. That will be 110 webinars for FEMA Region 2 this year, at least for the preparedness division. So if you look on your screen right now, you'll see that we have the same webinar on the 17th in Spanish. We also have a part 1 and part 2 about assistance animals and pets, the influenza vaccine. Tonight, Allison and I will be joining CISA, DHS, and New Jersey's Office of Homeland Security and Preparedness for a symposium for houses of worship on cybersecurity and what other resources each of the agencies has available to assist houses of worship next month. So we are taking a 2-week break today, and we are already fully booked for January and I believe most of February. So addressing mental health of young adults, powerful presentations. We are going to be partnering with all the other regions throughout the country, starting with Region 1 in Boston, Region 3 in Philly, Region 4 in Atlanta, do 10 webinars in 10 weeks on different steps to preparedness that individuals or families or small businesses or schools can take to be better prepared in 2021. Series is titled Resolve to be Ready, 10 Steps to Preparedness. And then finally, today's webinar and all of our webinars have been recorded. You can click on the recordings link and it'll take you to all the webinars we've done this year. We ask that you give us about 2 weeks to get today's webinar posted, but if there's somebody you know who would benefit from listening to this content, you know, they can see the whole thing in its entirety, including the transcript and the captioning pod. So we're ending 10 minutes early. I'm giving everybody back 10 minutes of their day. Thank you all so much for joining us. And I believe it's Happy Hanukkah today, but everybody enjoy your holiday and have a blessed New Year. And let's all resolve to be ready in 2020.